I'm Trish Power Scott.
And I'm Lynn Loria.
Welcome to Two Cents of Sunshine.
We're excited today to have our friend Sam Gomolka here. Sam is not only mother, military wife, she's a physician's assistant, she is a cancer survivor, and her most recent achievement is certified in menopause practitioner. So we are super happy, super grateful
So great.
to have you here, Sam.
Hi.
And hello, friends.
And we forgot to mention her best attribute, our good friend. We are the lucky ones,
we
for sure.
And I know, Sam, we have had the privilege of talking to you and getting to know you. And I think that I speak for Trish, that we've all had the same mindset of hormone replacement therapy is a positive thing for all women. And with the recent discovery of the black box removal warning last week, we are super happy to be able to bring you on, especially today, to maybe share a little bit of your story, if you will, and tell us how you are so passionate about it as we are.
Well, I've been a PA for about 13 years, and I practiced in gastroenterology and dermatology. And in the spring of 2023, my husband was gone, so he was on TDY, and I noticed some very vague symptoms that any busy mother woman would initially brush off. So I had decrease in appetite, I had some abdominal bloating, I was tired all the time, more than normal, change in bowel habits, but nothing really that sent bells off. I ended up buying a new bodysuit off Instagram to give me a snatched waist because my clothes weren't fitting well.
Right.
I was sleeping at the library during my son's tutoring sessions. And it was one morning, it was actually my husband's birthday, that I woke up and I was just kind of palpating my abdomen to see if I could feel anything. And I hit a mass. And it was right below. Mike had come home and I woke him up and I shook him. I said, "Can you feel this?" And he put his hand on my abdomen and he whispered in the dark, "You're scaring me." So I went to work that day, and one of my good friends who was a PA, she worked in GYN for years. I said, "Julie, I need an abdominal exam." And she put me on the table and she was palpating and she looked at me and she goes, "You need to get to a doctor today." So they canceled my schedule. I made a call to Southtowns. They got me in that morning and I had an ultrasound, and the ultrasound revealed an 8-centimeter mass. So then they sent me to Quest and I had a CA-125 drawn. And then we waited. So I went to work the next day when my lab results popped into my email, and my nurse manager, she goes, "Don't open that email." How can you not? My lab results were 8 times what was normal. So I ended up getting in for an MRI. So the final measurement was a 16.5 by 9.5 by 8.5 tumor. So if you measure that out, it was a tumor the size of a football in my abdomen.
Unbelievable.
Right. So then I got in with an oncologist, and that was a Monday, and they were scheduling me for a hysterectomy the very next day. This was all within 6 days. So the weekend before, I was kayaking with the kids, and my son, much stronger than I am, we carried both kayaks back to the warehouse at once. And I was dragging my leg behind me in the office. I thought I pulled a hamstring. And I mentioned that in the review of systems, leg pain, 10 days. So the doctor called while I was getting my pre-op workup, and she goes, "I just want to add on a Doppler just to make sure everything is good before surgery tomorrow." I ended up having 2 DVTs. So I had 2 clots.
Or surgery.
Yeah.
Oh, thank God.
Yeah. So
Wow.
the morning of my hysterectomy, I ended up having an IVC filter put in. They started me on anticoagulation, had the hysterectomy. I had a 1.5 liters of ascites in my abdomen. It was wild. And the shock of that, I worked in a field where these symptoms are all, how many times did I hear that as a chief complaint with patients?
Right.
Sure.
And I was 42, I was very arrogant that this couldn't happen to me. I'm healthy, I exercise, I'm not a smoker, I'm not on birth control, like all these things that you kind of tick off as risk factors. It didn't apply to me. I just never thought it could happen to me. And so that started down 6 rounds of chemo, and I'm BRCA2 positive. So I had an elective bilateral prophylactic mastectomy and reconstruction. 2023 was wild.
Tough.
It was
Tough.
wild.
Yeah.
My goodness.
So what did it originally start as, the tumor? How did it grow? Like, where did that come from? Do they have a reason?
Well, BRCA2 positive.
Okay.
So my family has genetic history where we are at elevated risk for not only breast cancer, which my mother had, but ovarian cancer. BRCA2 also puts you at elevated risk for pancreatic cancer and also melanoma.
Wow.
So having that genetic testing, which I declined in the past. I knew that I had family history, and it was just a personal decision now that I don't know if I would make the same decision. I thought the weight of knowing that I was BRCA2 positive would be too much, that I would always be looking for the when or what if.
Or like even in your mind, like creating symptoms, like people do that, right? Like
Yeah.
everything instead of the exact opposite of what you did.
Exactly.
Go, I have whatever it is. And is this a problem? Right. And just living with that all the time.
At that time, I didn't know if that knowledge would be power. Now have been
Gone
through
through
this,
it.
I completely would have made a different decision. I think that information would have been power for me to have better surveillance, breast MRIs, having a GI specialist where I'm alternating between endoscopic ultrasounds and MRIs of my pancreas, MRCPs. It would have given me knowledge on how to approach the situation differently. And so I take that lesson and I'm using it for my own children now.
Absolutely. How quickly do they think that it grew to that? I mean, that's a large mass. Well, I thought I could outrun a mass, or I could
Yeah.
stop eating carbs and get rid of a mass. Like
Yeah.
it was like this, like, oh, what could I do to get rid of this pouch in my stomach? But it was a mass. So how quickly do they think that grew?
I've never had that conversation.
Yeah.
I was up to date on all of my gynecological exams. I went for, and what's wild is that March of 2023, I went for my mammogram. And it's just that the irony of I went for a surveillance test for cancer when I totally missed where the actual cancer was growing isn't lost on me. But ovarian cancer is the most deadly gynecologic cancer because there isn't a screening measure for it. So breast cancer, we have the mammogram. Cervical cancer, we have the pap smear. There's other modalities, colonoscopies for colon cancer. Ovarian cancer,
There's nothing.
No, it doesn't get diagnosed until the later stages, typically stage 3, stage 4, after it's metastasized, where it's large enough to create symptoms.
Which was considered stage.
No, I had stage 1 of carcinoma. So mine was limited to the ovary because I was stage 1C. Covering of the ovary did break when they did the surgical removal. So that's what put me into the realm of getting the chemotherapy more for prevention.
Sure. Make sure.
Yeah.
So say that again. What broke? The seed?
So the capsule.
The capsule broke when they were taking it out. So essentially, it could have spread cancer cells throughout your body.
Potentially. So hypothetically, the chemotherapy is used to make sure that there aren't any cells in the abdominal cavity.
What a crazy journey.
Yeah.
Right?
Wild.
Like, it's wild.
Yeah.
And it was so fast. I even remember during that time, everything just happened so fast. There was no room to process.
There wasn't.
No.
There wasn't. And even during chemotherapy, the mindset is just get to the next.
Get through today.
Right.
Yeah.
Get through today.
Yeah.
So I went through 6 rounds of chemotherapy. I initially started with Doxil.
And that was, right. You just did not have like the smoothest road of any of
But
it.
it gave me good life experience.
I love that mindset. A tough way to have that.
Yeah. So I ended up going through the last 5 with carboplatin and Taxotere, which was a better fit for me. But the hardest part was actually after chemo ended. And I see a lot of, videos of ringing the cancer bell, and I love that for people. I do. I celebrate that. But I personally look at ringing the cancer bell much like I look at military reunion videos on YouTube. For people on the outside, it looks like this joyous occasion, but for the people who are in it, it's very different. So you ring the chemo bell and it's victory, and I wore a tutu and I celebrated. You still have to go home and be sick for 5 days.
Yes.
You still have to go through that, and not having that structure of making it the next 3 weeks until my next session, you're just kind of released and you're like, okay, you're good. I was very much not good. And I don't think we were connected on social media.
We weren't connected until later.
Crying on the internet phase. I cried on social media for months.
I known you. Had I known you, I would have run straight to you.
Do you know how many people you probably helped by doing that? Like, she literally would walk her property and talk about what was happening that day. This is how I feel. This is what's going on. Do you know what people you helped? Like, so maybe it's just bigger than you all as a whole. I believe in that, right? Like, I believe that God has things happen, and there's things that are put for a reason in your life, right? And that is so you can share and you can help other people. And you did exactly that, right? Like,
whoa, I needed some more. I wasn't.
I mad. Oh, this is weird. Yeah.
I was depressed. I was fatigued and not even just tired. I could have a good morning or a good afternoon, not both. The joint pain. Yeah. I was using the handrail to walk down the stairs. The weight gain from my initial chemotherapy. I had a terrible reaction. So I was on dexamethasone for the next 5 months. So I gained 50 pounds during chemo. So there's that grieving. Right. So you went through something very traumatic you need to work through. There was that sheer hormone imbalance, and surgical menopause is very different than natural menopause.
Okay. Yeah,
So
you both
I
did
did
that.
too.
Yeah.
So we share them.
Have this abrupt loss of estrogen, progesterone, testosterone. Testosterone in surgical menopause patients drops much more dramatically than in natural menopause.
What about the others? And we had talked about this too. So the progesterone and the estrogen, do those also just drop bottom out?
Oh, they take they're gone. Yes.
Yeah.
And where someone's starting, I don't mean to interrupt. Yeah. Someone's starting perimenopause. We think you're starting, right?
Yes. Yeah.
Symptoms. You could be in perimenopause for 10 to 12 to 15 years.
And
so what happens in a surgical menopause is you are just going over that 10 or 15 years just happened over. So you are not given that grace to just slowly inch with like a million horrible symptoms. Yeah. You just end them. And then there wasn't a lot of help at all. There was not a lot of assistance. People sort of
wasn't a discussion.
So you didn't know.
Yeah.
And now you're suffering.
And I love my oncologist.
Yeah.
I love my PMD. I think that I have a very strong set of doctors who care for me. But where does that discussion happen? Where is the appropriate appointment where that discussion happens? Because when you go for a wellness exam for your primary, I've been a provider. I was a provider who was a patient. So I know both sides of how this goes. You have 15 minutes to get in. You have all these checkpoints you need to hit. You need to create a treatment plan. And then you have 16 other patients to get through before lunch. So it took me 4 providers before I got my first prescription for estrogen. And I started on oral estrogen, not progesterone, because I didn't have a uterus.
Same.
Which they are now saying that's a fallacy too, that you actually do need progesterone even though you don't have a uterus.
So it's a nuanced discussion. If you have a uterus, you have to have a combination of estrogen and progesterone so that you do not have unopposed estrogen, which can put you at risk for endometrial cancer. So that's their best friends, right? If estrogen is the gas, progesterone is the brakes. But progesterone has so many other benefits in your body. It helps with resiliency. It works on the GABA receptor, so it decreases anxiety. It can promote sleep. So not having a uterus is not a contraindication for progesterone. I take progesterone 200 milligrams every night before bed.
How long before you were prescribed it? It took me a long time before I'm like, why am I still having symptoms?
Last year.
So I went like 2-3 years just on estrogen.
Oh, wow.
And I think I said last time my husband is a retired gynecologist, but I would be like, Phil, why am I still? I can't sleep, irritable, the anxiety is coming back, the hot flashes. I'm like, either we need to really up this estrogen, or he's like, well, you could probably, talk to the doctor about progesterone. I'm like, dude, like, why don't we say this? Like, but yeah. And so building
now
and then getting to testosterone.
Now with the black box labels of hormone replacement therapy gone, do you start right out of the gate with all 3 or do you lean into them? How does
such a good question?
So I feel like you two are really knowledgeable, and I'm like the consumer, every consumer at this point, right? Like every patient.
Well-rounded.
Yeah.
Right. So everything changed in 2002 with the release of the Women's Health Initiative, which was the largest randomized control study at the time. It still is the largest, and it was looking on the effects of hormone replacement therapy on risk of cardiovascular disease. They ended up stopping the study because they erroneously stated that it increased your risk of breast cancer. So in the 90s, up to I think 40% of women were on some kind of hormone replacement therapy. What was used in the past is not what's used today. So in the study, they used something called CEE, or conjugated equine estrogen, with a synthetic progestin, which is medoxyprogesterone acetate. We do not use that anymore. We use bioidentical now. But you went from 40% of women on hormone replacement in the and early 2000s to almost nothing. It stopped overnight. And so now, 23 years later, only about 7% of women are on hormone replacement therapy, which is tragic.
It's so tragic
for a number of reasons. But it also, the way it changed is med school, there's not extensive modules on how to treat hormones or menopause. And what's shocking is that you realize that not every woman will experience childbirth. Every single female will experience menopause. And how is it not its own division in medicine, its own specialty? The discussion of hormones is you have to look at contraindications. What are the symptoms? How are you treating the patient? So you have which used to be called H.R.T, then it was called MHT, menopause hormone therapy. And now the menopause or the menopause revolution that's happening, they call it PET, so progesterone, estrogen, testosterone. Really to have a well-rounded approach that females need all three, and that testosterone is not just a male hormone. So when you're looking at hormone replacement, we're looking at those three hormones. You have oral estrogen or transdermal. You have progesterone, or sometimes if patients don't tolerate it, you can have synthetic progestin. You have testosterone. And then you also have a role for local or vaginal estrogen, which is amazing.
Interesting.
And absolutely, just to go off that point, and if you really do some research, every female pretty much needs to be on the estrogen that is local in the vagina. It is not just for people our age that want to just enjoy a healthy life, even to the point where some people, it affects them so bad that they can't walk. I mean, it gets so uncomfortable. Elderly people should be on estrogen cream right now for urinary problems. Elderly, 80s, 70s, 80s, and 90s. These females are struggling with UTIs more than any other age group of females, and they're not going to get treated. So they're not getting treated. They end up with sepsis.
Urosepsis.
They end up with,
So dangerous.
right?
So vaginal estrogen, which is local estrogen, does not raise systemic levels. Even with the advancement last week of taking the black box warning off, vaginal estrogen would be safe for breast cancer patients. And what it's treating is called the genitourinary syndrome of menopause. And so that is vaginal dryness, that's vaginal atrophy, that's pain with intercourse, both the external pain or even deep pain, dyspareunia. It helps with increased vascular blood flow. It decreases urinary tract infections. There's really no contraindication for a patient to be on local estrogen. It's amazing. A patient has a history of breast cancer and isn't comfortable pursuing vaginal estrogen based on their personal beliefs. There's other options like Interosa, which is a vaginal DHEA, or vaginal lubricants. But first line, gold standard, vaginal estrogen is fantastic.
Wow.
And
I had no
save
idea it
lives.
was even an option.
Yeah, for sure.
Yeah.
Absolutely. I'm sure I cannot even imagine walking in your steps, Sam, and what you went through. Because just with me, it was basically a hysterectomy. I think that doctors for myself think that because I'm married to a GYN, I just automatically know everything. So I
That's
again woke
interesting.
up and knew nothing. And Phil, God love him, he was just telling me as I was having symptoms what was happening. He was super helpful, but people just assumed she knows. But they didn't tell me. And it was really scary. But I remember having all of this onset of 100 symptoms at once, and the anxiety and the depression. And at that time, I know we've talked military, but my military boy had just deployed, and I was literally sitting in a corner crying. My kids are seeing me not able to function. And I'm like, that's not me. If you know me, I might have some anxiety, but I'm not depressed, right? Yeah. So once I started taking the hormone replacement therapy and I started feeling almost immediately,
it's life-changing.
I remember saying, this is literally, 6 or 7 years ago, I would trade 10 years of my life. I will never get off of
Told
this.
me that. First met
Never
you told me
get
that.
off of it.
Yeah.
And that is
So that's an important statement
Mhm.
that you make, because you have to understand what the indications for hormone replacement therapy are. And you also have to take into consideration something called the timing hypothesis. So not every patient is a candidate for hormone replacement therapy. You can use H.R.T for treatment of vasomotor symptoms, so hot flashes, night sweats. You can use it for concerns of osteopenia. You can use it for treatment of genitourinary syndrome of menopause, or if there's surgical menopause up until the age of natural menopause. So those were the indications for treatment. But also, when you get into the timing, early hormone replacement therapy is so important because it helps to prevent cardiovascular disease. It helps to prevent osteopenia, osteoporosis. It helps to prevent cognitive decline or dementia. But that's within 10 years of menopause. If you get into 10 to 20 years from your last menstrual period, there's an increased risk for cardiovascular disease or clotting events, but it's not statistically significant. Only after 20 years does the risk versus benefit kind of switch. And the way the estrogen works on different pathways, it can actually put the patient at significantly higher risk for adverse effects. So the women who suffered 23 years ago are not really candidates for systemic hormone replacement therapy at this time. We'll talk about vaginal estrogen all day long, but unfortunately, their risk versus benefit profile just doesn't
It's
fit.
not there. I have so many questions now after this. Okay, so and I'm sure other
People
will.
Do you have
So
questions?
my understanding is, or I guess not even an understanding, it's just my thought process on it was that I'm going to hold off as long as I can because it seems like the less amount of time that I have to put these things in my body, the better it will be for me. So that's an absolute.
Help me understand why you did it.
I don't know. I think that, okay, so if your body stops creating it, right, you're lowering how much estrogen or progesterone you have, and of course your testosterone too. If you stop creating it, it's going to go down slowly. So if I let my body accept that and then I add it back in later, I just feel like I'm adding less things and that's somehow better for me. It's right. It's the
way we frame it.
That's the way we frame it. It's the social media frame of mind too, like, are the things that we read, right? Like having the black box warning. I know all about it. So it's like, we'll just wait a little longer and then you won't have to have the fake things, even though they're not really fake. They're really what exists in your body. But that's like the mentality of it. So that's a fallacy. So if I'm having symptoms, God love my husband, but I'm like, I really am having premenopausal symptoms. My ears ring. Like you can't make that up.
No.
Like, and they itch so bad.
Your skin will.
I told you both. I thought I was having a good Chinese proverb of luck or something. I was like, I have itchy ears. This has to be
like,
girl, this is not a good omen.
That is not good luck. Good luck is this last week that happened.
Right. Yeah.
Black box.
And sweating at night. I'm hot at night. Like that is like not. That's odd for me. And then I'm anxiety. Like, but then you do these things, and I'm sure people at home think this too. Wait, of course I'm anxious. I have 3 little kids that I'm worried about all day long. Are they going to get hurt? Are they going to this? Of course I have anxiety. Well, wait, no, but I didn't have anxiety like this 6 months ago. So you really have to pay attention to yourself, right? And then, so it's like, okay, now I'm here. I have these symptoms. Do I do something about it right now? Or do I wait until it's unbearable? Like this is, I think, where we just don't know what to do. And like, what's your step? What do you do now? Do you go talk to your GYN about it?
I want to go off this one too, because I know, where Sam is in the medical community, I'm in the mental health.
Right.
And when we talked about how I stopped treating children after COVID, I started with 17 and older. And a lot of females were coming to me, usually 39, 40, and up to like 60 and beyond. One particular story I have that just hit me so hard was this lady who came to me from ECMC. She had tried to commit suicide, and there was nothing that changed in her life except that she was severely suffering from symptoms of menopause. So to hopefully go off the point of maybe what Sam's going to share is don't let something wait till it gets to that point. Another thing that I will assess my clients with, if they never had a history, if nothing life-changing is going on and you don't have any major adjustment in life, we need to, I'll usually send them to their doctor, get some blood work. Let's check your thyroid, your B12 and everything else to see if that's it. But I'm feeling that you might want to talk to the GYN about hormone replacement therapy if there is nothing else and we rule everything out. Once they do that, it's like, because I think the mindset is to put everyone on an SSR, Lexapro or Zoloft or an antidepressant, and that's not treating it. If it's a hormone problem.
That's a whole other episode. So what happened, because a lot of my patients that come to me, I don't feel like myself. And they try and advocate for themselves within their conventional medical appointments. And a lot of times they're just not heard. Where the SSRIs come in, because I was angered actually for a lot of my patients who were put on antidepressants for perimenopausal symptoms. And I was angry. In studying for the Menopause Society Certified Practitioner Board exam, SSRIs are a non-hormonal treatment for perimenopause, menopause symptoms. So you have paroxetine, 7.5 milligrams, that can be used for vasomotor symptoms. The role of SSRIs could have a place, but I think the gold standard again would be hormone replacement, but that's not an indication for treatment. So you have to kind of look at it in a different way. 1 in 2 women are at risk for a traumatic fracture frailty from osteoporosis or osteopenia. So basically any woman could qualify.
Does that start at a certain age?
Well, you lose bone mass when you hit menopause.
Yeah, right.
That's significant. Your highest bone mass, I believe, is in your early
20s. Yeah.
And then you start losing it.
Right.
Yeah.
So high impact, exercise, box jump roping, carrying weights is Dr. Vonda Wright is one of the menopause huge advocate for lifting as heavy as you can go, farmer carries.
Really?
Yeah.
I mean, we all know that's my answer to everything.
That's
if you don't feel good, Go exercise.
Go hit a bath.
Water and a walk. Anything you need, everything is exercise and a
Right?
glass of water. That's
Yeah.
my answer to everything. Well, this has been so great. And I know we want to continue on next week. Join us for our follow-up and we're going to talk to Sam again next week. But thank you so much for joining us. If you have any questions, we'd love for you to let us know what they are. We can answer them for you. But thanks for joining us and we'll see you soon.
Thank you.